at least on my screen. This talk is, there we go. This talk is going to be looking at what it seems a lot of people in the audience are using quite a bit, which is autogenous bone graft, but maybe looking at a new twist on it. In my disclosures, you can see them here, and most of them I don't think have anything to do with this topic, but one thing I do want to note is that I am a consultant for Medtronic, who of course makes Infuse or BMP2, so just wanted you all to know that one. And I'm getting a note that my camera for some reason is not going. Roman, any idea why not? Because I'm not sure how to change that. Okay, let me see if...
Your slides are good.
There we go. There we go. Hopefully that got it on. Sorry about that. Bone defects and acute fractures with defects or non-unions are a big problem for all of us, and there are a lot of new products. We've just heard some about BMP. There are things like stem cells we haven't really gone into too much yet, and then there are our old standbys, which are the autografts. And again, seeing the audience's answers, clearly autografts are still a major player for many of the people that are watching this. When you see an injury like this one happening in this Alabama versus Florida football game where this wide receiver, Tyrone Prothro, had a nasty open tibia fracture, the question that we've already touched on a little bit is, what can you do to take care of a fracture like this? This did go on to a non-union. Not sure what happened, but there's the slide again. And what do we do to take care of this, either acutely, because this was contaminated, or in a delayed fashion? And I'm a simple guy, kind of, and I look at these in major categories. And I'm not sure why the slides are slipping back on me, but anyway. And those are that we have the osteoconductive products, and those are somewhat the trellis for the plants, and then the osteoinductive, which are the Miracle-Gro or the fertilizer. So we've got our osteoconductive, which will allow the bone to grow up through a trellis that's really just supporting it, and that certainly has a major role. And then we've got our osteoinductive, and that's really fertilizers. And there may be more than one type that plays a role here, as you can see with two different types of Miracle-Gro, but trying to sort all these out is our job. Well, what about autograft? Where does that fit into all of this? And there we go. My screen is having problems here. I hope everybody else isn't having the same problems I am, because my screen is going blank on me. Okay, I'm getting it back. Sorry about that. So anyway, in my hands at least, the autograft has become something that I stayed away from for a little while because of significant problems with harvest. And specifically hematomas, infection, and pain was really the biggest one. Patients didn't like it at all. I didn't like the fact that it took time, but what I really didn't like was the problems that a lot of my patients had. And I abandoned it to a large extent for a while as many of these new products came on board. But for me, it really does have a role, and if we're going to use the garden analogy, for me, the autograft is the manure. And any good gardener knows that you need some manure to make the garden grow well. So I think that it has a real role. Bone grafting is done quite a bit, and again, the people in this audience clearly are seeing quite a number of cases where they're doing it, but we still have a significant morbidity problem with it. And I saw that personally both with my daughter, who had a bone graft done on one side and not on the other with subtalar fusions and had pain for 6 months or more. And then I also had another side where she had a substitute and did not have that problem. And so my slides are coming in and out. I don't know if everyone else is having this issue, but anyway. So I had gone away from bone graft for a while, but now there's a new option, and that's harvesting bone graft, as you can see on your screen, hopefully, which is using the Reamer irrigator aspirator to harvest it from out of the femur. And that really has gotten me back to where I make significant use of bone graft. I'd like to show you briefly how this is done, this is an example, what you see on your screen right now, of the Reamer irrigator aspirator. It was actually developed with the goal of treating patients with significant chest injuries who had femur fractures. Secondarily, people figured out, we could potentially harvest what is being aspirated out of the femur and use that as a source of bone graft, and that's what many people have now started doing. So it's actually a femur reaming system, but if you set it up correctly, you can harvest the bone graft. Here's an example of quickly how we do it. This is a typical opening canal reamer for making a trochanteric approach to the femur, and I'll put that over the thigh and take a fluoro view, and this is a 13 millimeter reamer in this particular case. So I'm looking at that versus the size of the canal to decide what size reamer I want to harvest my bone graft. And what I will do, that's an example of a 13, and clearly this canal can take bigger than that. So if I want to harvest bone graft, I'll typically, in a case like this, do something like a 14 or 14 and a half. This is a disposable one-pass reamer. So in this case, you're going to pick your size. So in the case I just showed you, I'd probably pick a 14 and a half or so and connect it to this disposable reamer suction apparatus that you see pictured here. You then pass a typical ball-tip guide wire down after doing your opening reamer. And once you do that, here's the start guide wire in, opening it with the 13 millimeter reamer, as you see here, just like any trochanteric nailing case you would do. And then you pass your ball-tip guide wire down. You want to center it in the AP view, but what really matters is you want to center it in the lateral view, because this is a very sharp reamer and you don't want to nick the anterior cortex and run a risk of a supracondylar femur fracture, especially if this is an elderly patient. Once you have done that, you then set it up with these canisters that can trap the reamings that are being suctioned out. In this case, these are two Biomet filters, which are a little bit smaller filters, and in the top one we're catching the bone graft, and in the bottom one we put some beta-tricalcium phosphate granules, which the same fluid that we're aspirating out is bathing them, and I'll show you what that does in a minute. There's a filter now that's made by Synthes as well. That is a bigger filter, and you can use just one filter if you want to use that one. So either way, I've done it both ways, and I think both work quite nicely. When you do this with the dual filter, you can see on the left I've got the bone that we've harvested in the top filter, and then on the right the beta-tricalcium phosphate. We then did a study when I was at UAB where we tried to look at this, and it was 16 patients, all of whom had non-unions. And in the case of these patients, you can see a little bit of the demographics there. Almost half were smokers. Almost half of them, or I guess a little over a third of them, had prior infections of the bone involved, and more than half had open fractures previously at this non-union site. We were studying the use of this reamer irrigator aspirated harvest bone, and you can see it took about a 3 centimeter incision in most cases to harvest it. Pretty moderate blood loss. It's got a volume of graft of an average of 40 cc's, but I will tell you that totally varies depending on what size reamer you choose. On the smallest amount we harvested, 18, it was a foot case, and we didn't need very much, so we didn't choose a very big reamer. In the case of the 55 cc's that we harvested, we needed a lot of bone, so we picked a bigger reamer. So you'll kind of get what the amount based upon how much you're trying to harvest and the size of the reamer that you choose. We did not experience any complications from reaming during this study. Here you can see we got analog pain scores daily for the first week and then weekly after that until we got to 6 weeks, and then we did it again at 12 weeks and then 24 and 48. And what you can see is the harvest site is certainly not pain-free, so this, while I think it's better than iliac crest, we compared it to the non-union site where we were doing the surgery, and you can see that at the beginning the score at the non-union site was a 7, whereas the harvest site, the femur, was a 5. For the first week it stayed about a 5, and the non-union site dropped, so they were about the same at a week, but then you can see the harvest site from the femur drops pretty quickly down to the 1 and 2 level by about 3 or 4 weeks, so it ends up with a relatively low amount of pain compared to what most of my patients previously experienced with the iliac crest harvest site. I wanted to show you a little bit of when we studied what exactly is in this. And there are 4 things we looked at here. We did an iliac crest aspirate on these same patients, so that's the top block that you see here. Then we studied the bone that was in the first trap. Then the beta-tricalcium phosphate. In this case it was Kronos, but I don't think it matters whose it is. And then the last thing we looked at was at the end you've got the rest of the wastewater that's being collected in a bucket, and we studied what was in there. When we looked at VEGF, what we found was that there was an amount in the wastewater that was almost as high as what was in the iliac crest aspirate, and both the bone and the beta-tricalcium phosphate had substantial amounts as well, although it was lower than the iliac crest aspirate. interestingly to note, and you'll see this in all of these slides, the bone had about the same amount as what was caught in the second trap on the beta-tricalcium phosphate. So that wasn't just a passive filler, which when we did the studies, what we thought we were getting, but rather it was actively catching some of these bioactive proteins. When you go to BMP2, you see the same thing. Iliac crest has a little bit more than either the bone or the beta-tricalcium phosphate, and the wastewater has even more than iliac crest. So there's a lot that we're throwing away when we do this that a lot of people are looking at now. How could we capture that? When you go to TGF-beta, you can see both the bone that we're capturing and the beta-tricalcium phosphate have enormous amounts, more than double what was in the iliac crest aspirate or the wastewater. And then the last thing we looked at was total proteins. We didn't specify which one, but total proteins. And again, you can see that the bone we harvested and the beta-tricalcium phosphate each had about triple what the iliac crest aspirate had. So the only point in this is there are a lot of biologically active proteins present that are being harvested and that you're getting when you're putting this iliac crest graft in. Femoral graft in. So what did we learn from this study? Age didn't correlate with how much you were getting. So older patients had just as much of all of these things except in the VEGF. That one, there was a near correlation to age with older people having less. Reamer size did not correlate with the volume of graft because it really had to do with reamer size compared to the canal size. And the granule size of the beta-tricalcium phosphate made no difference. We used two different sizes. This is what it looks like, kind of almost like a snowball you can make of it. It's a slurry of bone that makes an ideal filler we found when we match it with BMP2 or BMP7. It seems to have a synergistic effect with it because some other people have looked and it also appears to have a large number of pluripotential cells that you're harvesting as well. So this in some ways can ignite the BMPs if you mix the two together. So for really difficult bone loss cases, in my hands right now, this has become kind of a technique of choice where I mix them together. So an example where I've used this is using the technique that has been pushed by Ron Lindsay and Peter Osterman when you have a large gap of potentially doing a titanium cage with an intramedullary nail down it and then packing this bone slurry harvested from the femur with BMP around it. And I've had pretty good success with up to 10 centimeter defects doing that. And here's an example where I'm using the bovine collagen sponge soaked with the BMP, and then I'll pack this bone around it, and you can see the beta-tricalcium phosphate granules there as well, all mixed, and make it into just a big fajita and pack it in there. So for me, autograft has really become a big player again because of this new way of harvesting it that allows me to get a large volume relatively quickly and through a fairly small incision with, in my experience at least, less pain. This new harvest method has made it much more attractive to me, and interestingly, as you study it, you find a large volume of biologically active proteins as well. Again, it works very well with the BMPs also, and I think there may be a real opportunity in the future if we can figure out how to take that wastewater that currently is being thrown away and gather the proteins out of that, because there are a lot of them there. Thanks. I'll be happy to take any questions as we go on.
That was great, Jim. I have a couple of questions from the audience here that I think are worth looking at. Number one, at the OTA meeting this past year, there was a fair number of reports of pathologic fracture occurring following RIA, so reaming these closed canals. So what do you think the problem is? Is it over-aggressive reaming or eccentric reaming, or is it just the patient selection? Maybe we shouldn't be doing it on elderly patients, but of course this is the type of patient that's going to require some other type of graft modality because their iliac crests just don't have anything. So what do you think the genesis of these fractures is?
Yeah, we did it quite a bit at UAB, and it was all of us doing it, and we saw two total fractures that occurred. One of them was a patient who had a significant trauma afterward, and there's no doubt you probably weakened the femur to a degree, and it was an elderly patient, but they also had a substantial trauma. The other one was a case without question where we got into some eccentric reaming. Both of them were older patients. I personally never had it happen, and I've done it quite a bit, and I think that it's absolutely essential, and that's why I tried to show that slide, and hopefully it came through since they were having some problems with my slides. But you have to carefully get a lateral and make sure you are really centered, because I think if you're going to get one, most of the fractures that I'm aware of have been occurring in the supracondylar region, and they've been occurring in situations where people potentially let that very sharp reamer get anterior, and that's what I think is the big risk. So you have to realize that this is not like what many of the reamers are on a lot of our sets where they're kind of dull. These things are a one-time use, and you have to be very, very careful in order to make certain that thing is centered. The other question again is you'll get more bone graft if you go with a bigger reamer, but you're also taking away more bone. So you've got to balance that. If you have an elderly patient, you might want to be careful about just exactly how much you're doing that. And then I know people who also will try and put the guide wire in the medial part of the supracondylar area, the lateral part, and move it back and forth and back and forth. I think you need to be careful of that one because, again, you're running a bigger risk as you go back and forth in that supracondylar region of fracturing the patient. So I personally pass it down to the supracondylar region once, but I don't go back and forth and try and get medial and lateral. If I feel like I need more graft, I try to grab it more from the midshaft where the bone is stronger.
Mm-hmm. So you'd upsize just for the midshaft portion, use a bigger reamer or a bigger diameter reamer.
Yeah, and just again be careful and try to balance how much you need versus how thick that patient's cortices are. And again, the other thing that I'd encourage is consider getting some of the tricalcium phosphate and putting it in the trap, because that had absolutely just as much of the biologically active proteins as the bone itself did. So you can double your volume that way, and potentially then not need to go with quite as big of a reamer and make it a safer process. So those are all tricks that I think can work to make that a safer move.
There's been a number of questions regarding the cost of the reamer and the equipment. What do you have a sense of how much this costs?
I do, because I just checked into that when we were doing the study, and I can tell you that in the dollars we were paying about 2 years ago when I was at the University of Alabama, Birmingham, the cost of the expendables for the reamer irrigator aspirator, one 10 cc packet or bottle of the beta tricalcium phosphate, and all the tubing and everything was right about $1,000, which was very similar to what we were paying at our hospital for 10 cc's of DBX. So harvesting with the Chronos or whatever other tricalcium phosphate you want to use was about the same as 10 cc's of DBX, or $1,000.
Another interesting question from the audience is, Rhea, have you ever done it retrograde, reaming through the knee?
I have not. You could. A lot of you guys probably know that I'm not real thrilled with retrograde nailing, period, as a guy who deals with the knee a lot. So I never have, because I feel like you can get through the trochanter so well, and I haven't. But it'd be the same start point as any retrograde nail, and you certainly could if you believe in doing that.
Right. One other question about the Rhea. Do you have any concerns with reaming a closed canal? I mean, with the closed femoral shortenings, we always used to have to vent the canal prior to reaming to avoid pressurizing the canal and fatal fat embolus. This reamer is designed differently. I think you probably need to explain the differences, because it's a pressure relief reamer, not like a toilet plunger that may pressurize the medullary canal.
And I realized I kind of blew through, and plus the slides kept popping in and out, so people probably didn't get a very good chance to look at it. But if you end up downloading my slides and look at the design slide that shows the reamer irrigator aspirator, like I said, it was designed for patients who had a chest injury, and the whole purpose of it was to suction out the reaming so that they did not go to the lung and potentially cause a fatal embolism. So what it does is as it's reaming with that very sharp reamer, it's sucking it out. So it's bathing water down the shaft of the reamer and then suctioning it back out. The net result of that is, even though it's a closed canal, it suctions everything right out. And so we actually, and I don't believe he's ever published it, but also at UAB, my prior partner Dave Voges did a transesophageal echo study, and it really had very, very little that was showering through the heart when you did the reamer irrigator aspirator. Then we did half the patients with conventional reaming, and this was in femur fractures, and it was a remarkable difference. So I think it's pretty effective at suctioning out the reamings rather than causing them to go to the lungs, even though you're in a closed situation.
Well, great. Interesting discussion on the RIA. I think we have time for maybe one case example or depending on how much discussion we get,